Um, I don't.
But at any rate, it's 10:46, and I don't want to impinge on the next presentation. I'll introduce Dr. Grace Chang, who is one of our exceptional audiologists at Seattle Children's Hospital. She attended Northwestern for her undergraduate studies and received her doctorate degree from the University of Washington here in Seattle. She has many professional interests, including equity, diversity, and inclusion, electrophysiology, and of course, pediatric hearing loss. And she's been an incredible investigator, and she's going to describe some of her work in this next presentation.
All right, okay. Dr. Christensen is just letting me know how to get everything set up. So I'm hoping that everybody can see my slides here. So today's presentation will be on, oh, hang on one moment. I want to make sure that I can see my own screen. There we go. Today's presentation will be on self-report instruments for children with unilateral hearing loss. Thank you for the very generous introduction, Dr. C. My name is Grace Chang. I'm an audiologist here at Seattle Children's. Here are my disclosures. I don't have anything particular to disclose other than I'm a salaried employee of Seattle Children's Hospital, and I am receiving an honorarium for this presentation. We will be talking about a study later on in the presentation, which was funded by the Seattle Children's Childhood Communication Center, and there's my email address if you have any questions later on. So it should be in those slides that were disseminated earlier. For this presentation, our learning objectives are threefold. Our first is to compare and describe 3 subjective assessment tools for use with the pediatric unilateral hearing loss population. The second is to define how subjective assessment tools help determine need for intervention for children with unilateral hearing loss. And the third is to identify areas of opportunity for future research involving self-assessment tools for children with unilateral hearing loss. Background, I know Dr. Sark did a really great job in talking about all the different research, and a lot of this actually overlaps quite a bit with what she talked about, but we can go through it briefly again. So when left unaddressed, unilateral hearing loss can lead to educational, communicative, and behavioral difficulties compared to normal hearing peers. Again, not anything that is new based on what information was presented earlier this morning. So you can take a look at some of those bullet points that I wrote down and some of those sources which overlap quite a bit. So I'm going to skip over this slide. But let's talk about this one a little bit more. Compared to children with bilateral hearing loss, children with unilateral hearing loss have similar rates of referred newborn hearing screening. However, their diagnosis of unilateral hearing loss tends to be later, and they're less likely to be fit with hearing aids or receive speech therapy services, as we went through before. So this was from a study by Brody et al. In 2024, which actually came out of Seattle Children's. Evidence has shown that children with unilateral hearing loss and single-sided deafness, or LUHU, may benefit from use of amplification, and hearing-related quality of life and listening ability actually improves with use of hearing devices. And we're going to talk about the consensus practice parameter again that Dr. Sarp talked about. So this is a really great document, and it outlines practice recommendations for the evaluation of children with unilateral hearing loss, which includes surveillance of speech and language and hearing abilities, screening of skills once concerns do arise, and recommendation for an assessment for hearing device technology once a need is identified. So how do we do this? Same flow sheet as you just saw. We really want to be using different tools, including regular audiologic evaluations, for which the cadence will depend on the etiology, age of the child, and stability of the hearing loss. So for example, there are etiologies of hearing loss which are more related to possible fluctuations such as EVA or congenital cytomegalovirus, which is associated with progressive hearing loss. Kids who are younger are not able to tell us when hearing loss is occurring. So, you know, a prelingual child is not able to say, hey, Mom, I think my hearing's not as good as before. So we need to be on top of that. And so you may, if you have a child who is younger who has a unilateral hearing loss or a bilateral hearing loss, you may have to come into the clinic more often than, you know, for a kid who is 12 or 13, for example. And stability of hearing loss. If we have some evidence that the hearing loss is fluctuating or progressing over time, we will recommend closer hearing evaluations as opposed to ones that are maybe a year apart. This also surveillance also includes routine developmental screenings in the child's medical home per AAP recommendations. So for those of you who aren't familiar with the term medical home, pediatrician or PCP. And early intervention services for professionals with expertise in hearing loss. So early intervention services are also known as birth to 3 services. In Washington, for the most part, these are provided, at least with the agencies that we work with most commonly, these are mostly provided online, but some of these are provided in person as well, and can include kind of auditory monitoring as well as speech and language monitoring. And lastly, and this is what we're going to focus on this presentation, auditory-related questionnaires. So self-report questionnaires to see how the child is experiencing challenges in their day-to-day lives in relation to their unilateral hearing loss, but also for families and other professionals, so teachers, therapists, and parents to see what they are perceiving in terms of their child's challenges. So how are questionnaires useful? Questionnaires can capture common listening challenges, for example, listening in quiet versus noise, spatial hearing, fatigue and listening effort, and effects on quality of life. And again, really harkens back to Dr. Tharp's talks in the morning, which were really great. So capturing common listening challenges can be really illuminating for families and teachers, since many children with unilateral hearing loss have developed coping and adaptation strategies to overcome their challenges. So, you know, they're doing just fine, but that doesn't mean that they're not experiencing them. So the use of questionnaires can really show that they're experiencing challenges that might be hidden somewhat. Questionnaires can also be really useful to inform audiological management. So does this child need a use of a hearing assistive device? Do they need it, and what is the outcome or benefit after they are fit? What accommodations can be helpful? So in addition to preferential seating, do they need a use of a remote microphone? Do they need some quiet time to decompress if they are experiencing more listening fatigue than other children? Do they need a captioner or somebody to help them take notes if they're having trouble? Things like that. And finally, education for the team that works with the child at school, or for the parents and the patient themselves. So counseling them on the importance of self-advocacy and the importance of accommodations and good listening strategies. So we'll be talking about 2-3 questionnaires in this particular presentation. We'll start with the SSQ. So the Pediatric SSQ is an auditory questionnaire, and it was adapted from an adult version. So the SSQ stands for Spatial, Speech, and Qualities of Hearing Scale. And for the pediatric version, there are 3 subtypes. There's the self-completed, the parent-completed, and the teacher-completed version. So the self-completed version is just kind of administer off the bat, but the researchers, Galvin and Noble, do recommend that for the parent and the teacher versions, that there's a 2-week observation period prior, wherein the parents and teachers kind of watch for particular challenges and behaviors in their children before actually completing the questionnaire. So interestingly, the pediatric SSQ is considered the gold standard for the unilateral hearing loss population in our clinic when it's used to assess listening challenges for children with unilateral hearing loss. But it was developed with children who had bilateral to severe to profound hearing loss. So the population that Galvin and Noble worked with were kiddos with unilateral versus bilateral cochlear implants. And so they were trying to discern whether having a second side cochlear implant was beneficial in different listening situations. So all the children in their cohort were kids who had bilateral severe to profound hearing loss. It was just whether they were bilaterally aided with a cochlear implant or not, or unilaterally aided. So a little bit sidetracked there. We have 3 subscales to the pediatric SSQ with a 33-item in total questionnaire. So the first subscale is speech, that's 10 items. The second is spatial hearing, so where sounds are coming from in space, localization and things like that, that's 13 items. And the third is qualities of hearing scale, so that is 10 items. So 33 items is quite a few items. It's a long questionnaire. So there are some condensed versions. The KID SSQ came out in 2022, 3, I believe, and that is a shorter version of the pediatric SSQ for the self-completed version. And then there's the SSQ-12, which was designed for adults, but I know clinically they use it is very widely used for kids with unilateral hearing loss who are older. And then there's also the SSQ-5, which is a screener, which is designed for adults as well. So I wanted to go through examples of questions in the pediatric SSQ, so all of you are familiar with what that looks like. So this is just a sampling of our questions. We're certainly not going to go through all 33 questions, but let's start with section A. This is how kids are asked to fill out the SSQ. So it's on this sliding scale rating of I'm not experiencing any difficulty at all versus so I can't hear anything at all, or I can hear perfectly. And kids are supposed to choose on the sliding scale how they are doing in a particular situation. So for speech, this is the first question in our section. You were talking with your mom or dad, and there is a TV on in the same room. Without turning the TV down, can you understand what your mom or dad is saying to you? And kids are going to rate can I hear in background noise? Basically, that's what the question is getting at. And then there's also options I would not hear it, I don't know, or it's not applicable. You know, maybe there's no TV in their house. Kids tend to be pretty literal. So there's options for that scoring as well. So this question 10, I wanted to point out this particular example because it really does illustrate how this questionnaire was developed on kids with unilateral versus bilateral cochlear implants who had bilateral severe or profound hearing loss. So is it easy for you to talk on the telephone with a friend or your mom or dad? So if we think about a kid with true unilateral hearing loss, theoretically, the answer would be, yes, perfectly. You know, I don't use my bad ear with phone. I just hold it up to my good ear. Whereas for a kiddo who is using CI, it might not be easy. That question is a little more nuanced. So perhaps there's more meaning to their answer in terms of how is their hearing device programmed, what is their use of it. Whereas for a kid with unilateral hearing loss, it's not as specific of a question. Section B addresses spatial hearing, so localization, finding where sounds are coming from in space. So question 1 of this section is, you are outside in a place you haven't seen before. There's a loud noise from a lawnmower or an airplane that you can't see. Can you tell right away where the sound is coming from? And so from what we know about unilateral hearing loss, this may be something that is difficult for kids because spatial hearing is very much a binaural phenomenon, right? So it might be difficult for kids with unilateral hearing loss to hear and find where this airplane is coming from. And so this is a question that is more specific and applicable to the unilateral hearing loss population as well as the bilateral hearing loss population. And so the spatial hearing section is really what makes this questionnaire very relevant for the unilateral hearing loss population. Another example is you can hear voices or footsteps. Can you tell how far away the person is just from sound? So this is again, localization in relation to distance, something that a kid with unilateral hearing loss may struggle with somewhat. So section C talks about qualities of hearing, so sound quality. The first question in this section is, you are in a room with music playing, someone starts to talk, will you know that someone has started speaking even though you may or may not know what they are saying? So this isn't a question that can be, it's more of it depends, right? Like, where is the person coming from? Where is the person standing in relation to my good ear or bad ear if you were talking to a kid with unilateral hearing loss? But for a kid with bilateral hearing loss, this may be challenging regardless. So a little bit of nuance that might be missing for a kid with unilateral hearing loss versus bilateral hearing loss on this qualities of hearing question. And I wanted to bring up this question because this is another example of, the vagueness of some of these questionnaires if developed on a population with bilateral hearing loss and applicability for kids with unilateral hearing loss. So you have to try very hard when listening to someone or something. A kid with unilateral hearing loss may read that and be like, well, what does that mean? Try very hard. Where are they standing? Is there something going on in the background? Whereas, again, kids with bilateral CI, that might be a different question. Either way, this is not a particularly specific question. So this is for the pediatric SSQ. This is what their experience of it would be like, children who are filling it out as a self-report. It looks very, very similar for a teacher, except it's do you as opposed to do you. Does the student have to try very hard to listen to someone or something? There are small differences for the parent completed version of the SSQ. There are sub-questions. So this is for the telephone question, and there is a sub-question of how often does the situation occur, and then they rank how often it occurs. And then the third part is how important do you think it is for the child to have the skill to address this type of situation. So that's our pediatric SSQ, and we're about to talk about a study in which we compared it to a different tool called the Unihilo. And so the Unihilo is also known as the Unilateral Hearing Loss in Youth Instrument, and it was developed by Purcell et al. Here at Seattle Children's in 2018 with a team. It's a self-assessment instrument designed for children with unilateral hearing loss to evaluate unique challenges. And it was developed using a cohort with unilateral hearing loss who answered validated questions pertaining to common listening difficulties for this population. So the team aimed to develop the functional assessment instrument that informs hearing health providers about the need for devices or rehabilitation. So it addresses 7 different domains: sound localization, head and body positioning, attention focus, safety, group activity and communication, relationships, and environmental factors. So a total of 30 questions. You'll see what it looks like here. So children are supposed to pick on a Likert scale on a 5-point scale ranging from 0 to 4, so 0 being never, 4 being always, and lower scores being associated with more listening difficulty in a particular situation. So they were just supposed to agree with rate how much they agree with the following statements. Section 1, sound localization, of course, something that is very relevant for kids with unilateral hearing loss because it can be difficult. Section 2, talking about head and body positioning, and I really like this section because if you see these 5 items below that header, there is reference to the deaf ear versus the good ear. And these are nuances that are very important for this population because their listening skill and ability really does depend on position of the speaker, whether someone's talking into their deaf ear or their good ear, even like anecdotally as well as in behavioral measures, right? And so this questionnaire, or at least this section, really gets to the nuances of their difficulties and their unique listening challenges with hearing loss just in one ear. Section 3, attention focus. I can focus on things even though there is background noise. So this is a section that can be a little more broadly applicable for kids with unilateral and bilateral hearing loss, as well as the safety question. That is also a relevant question for both populations. This section pertains to group activity and communication. It's trying to determine whether kids are having problems in groups versus one-on-one conversation. And again, something that is applicable to both populations, unilateral and bilateral hearing loss. Section 6 pertaining to relationships does talk about the good ear versus bad ear. So if you look at question 3, I feel comfortable asking my friends to speak towards my good ear. It gets at self-advocacy and whether children are willing to disclose that they've got a hearing loss. So it is something that is relevant for this unilateral hearing loss population in particular. And again, if we get to section 7, it's something that's a little more broad. So a combination of things that are specific to unilateral hearing loss as well as things that just kids with hearing loss in general experience. So in comparing the pediatric SSQ and the Unihilo, obviously, as everything has, both of them have strengths and weaknesses. So if we go through the pediatric SSQ first, a strength of the pediatric SSQ is that there are self-parent and teacher versions. So we can compare, right? What is the kid saying versus what is the parent saying versus what is the teacher saying? And that can be really illuminating for the parents and the teachers who may not be aware that children are having problems in a particular area. The pediatric SSQ is available in different languages. So because it's been published for a while, it's had the opportunity to be translated. So we all know that giving materials in someone's native language is better than having to go through an interpreter using the English language version, so that is nice too. There are abridged versions available, as I talked about before, and it can be used for bilateral as well as unilateral hearing loss. It wasn't specifically designed for kids with unilateral hearing loss, so it's a little more broadly applicable. Weaknesses of the pediatric SSQ is that it was adapted from an adult version. It wasn't particularly developed for children by children, if that makes sense. The sliding scale and the sub-questions can be a little bit confusing. So in our study that I will talk about, we did have some patients ask, and I'll go back to one of the questions just to give you an example. You are in a, or maybe not this one. This one's good. You can hear voices or footsteps. Can you tell how far away the person is just from the sound? And would not hear it is like, well, you already said that I could hear it. So in our study with our population, I had some clarifying questions of, wait, so can I hear it or can I not hear it? I'm confused. So the wording of these questions can be a little bit vague and difficult to answer. So thank you for letting me go back there. It takes a long time to complete because of the sliding scale, the way that the scenarios are worded, and the sub-questions. It was developed with children who have bilateral hearing loss, again, not unilateral, cochlear implant candidates. There is no normative data to compare to, and it is not validated. The Unihilo, on the other hand, was developed using a validated series of questions with unilateral hearing loss patients. It is very condition-specific to unilateral hearing loss, especially in the sections that I pointed out just now. It's quite easily administered because of the Likert scale. It's very kind of just right, can I hear it or can I not? Is it somewhere in between? And for that reason, it can be completed pretty quickly. Weaknesses of the Unihilo is that there's only a self-completed version. Right now, there's no parent or teacher version, and it's currently only available in English. There is no normative data, and it is not validated. And I do want to point out that the pediatric SSQ, interestingly, has been validated in other languages, but not the English language version. So given all that, we wanted to look at validation of these two instruments side by side, and we've decided to start with a reliability study. And this was a part of a larger study for which the other leg we'll be talking about in my next presentation with Dr. Christensen, but we'll start with just talking about this particular data set of the Unihilo instrument. So the aim for this leg of the study was to examine the reliability of the Unihilo instrument and compare that to the current clinic gold standard of the pediatric SSQ. Wanted to briefly introduce our study team. I apologize to the folks in this that I'm not reading your actual positions, but we are running out of time and I'm trying to be cognizant of that. So our study design was a prospective crossover design. We had 9 participants. I'll talk about why our N was so small in a little bit. They were aged 8 to 14 years with stable single-sided deafness, with typically developing with no comorbidities. Kids could have a 504 plan to participate, but not an IEP. And that was just to make sure that they are that they're performing at grade level and able to read all of the questionnaires that are involved on their own, and ask for clarification from the investigator only when necessary, so that we can essentially make sure that the questions are asking what we think they're asking, as opposed to needing clarification for every single one or needing explanation or having the questions read to them. And they also cannot have used a personal FM or DM system, BCSP, or a BAHA device or a cross system within the last 6 months. So this is more relevant for the next study, or the next part of the study. So single-sided deafness, Dr. Sark talked about that. It's also known as limited usable hearing unilaterally and generally defined as unilateral severe to profound hearing loss with normal to near normal hearing in the other ear. And it is the most extreme representation of unilateral hearing loss, which is why we chose to focus on this population in this study. The audiologic profile we used is basically a 70 dB HL thresholds or worse at our 4-frequency pure tone average range, and with the better hearing ear having a better 4-frequency pure tone average of 20 dB HL or better. We'll breeze through this. We're trying to examine the reliability of the Unihilo versus the pediatric SSQ at baseline, so with no device use. The whole study involved 5 visits. We'll talk about that in the next presentation, but I did want to point out in visit 1 and visit 2, all of the visits were about 3 to 5 weeks apart, and in visit 1 and visit 2, alongside other things that we did in the visits, we did administer the Unihilo, the parent part of the pediatric SSQ, and the self-reported pediatric SSQ at baseline, so with no device use. And at the second visit, we also completed the 3 questionnaires, again, with no device use for comparison's sake. This is a very technical slide that talks about the results of the study that we decided to leave in for reference for those of you who like that technical part of research. But I'm going to breeze through this and go to the next slide because it's a little bit easier to understand. So in comparing the Unihilo parent and pediatric SSQ, we were looking at the correlation of scaled scores over 2 visits to look at the reliability of the instrument. So a note for those of you who are not particularly statistics-minded that a correlation of 1.0 is a perfect correlation, which means that I answered, if I were to complete this questionnaire, I answered the same answer to the same question over 2 time periods, or over the first visit and the second visit. So the correlation of scaled scores over the 2 visits for the Unihilo was 0.96, so very close to 1.0, so it's excellent test-retest reliability. For the parent SSQ, so parents looking at their children and grading what they are determining to be their difficulty, 0.84, which is also considered excellent. But for the pediatric SSQ, so kids talking about what they're experiencing, filling out that different survey or different instrument, we had a correlation of scaled scores of 0.27, which is considered poor. So in conclusion, we found out that Unihilo has excellent test-retest reliability across the items. This supports clinical use to evaluate listening challenges for kids with SSD and unilateral hearing loss, and it can be considered for use during CI candidacy for SSD. Unihilo may also be a more appropriate self-report instrument to use for this SSD and unilateral hearing loss population than the pediatric SSQ based on test-retest reliability measures. And keep in mind, we'll talk about caveats real quick, keep in mind that we had a very small sample size. So this is an N of 9, very homogeneous cohort. All these kids were typically developing with the exception of unilateral hearing loss. So it's hard to say how these findings can extrapolate to kids with developmental disabilities and other developmental delays. There's a little bit of an age mismatch between the Unihilo and pediatric SSQ. So the pediatric SSQ was developed for slightly older kids than the Unihilo. So that may also explain some of our differences that we got in our study. And neither the Unihilo nor the pediatric SSQ are validated, so we don't have any normative data to compare to. Future directions, we could evaluate the study protocol in children with SSD with different age, etiology, and developmental differences. Certainly multiple language adaptations would be helpful, and a full validation study is warranted as well. Thank you for letting me go a little bit past my time. I'm going to bump it over to questions.
Thank you so much, Grace. You covered a lot of ground. Gave us good background. And it's interesting to compare one instrument to the other. And having these tools is really important for us to really start to understand who might benefit from intervention, what the impact is on these kids. I'll just give a little more background on the Unihilo development as the questions come in. So we held focus groups with this age group of kids with unilateral hearing loss. And so it was fascinating to read the transcripts of what the kids actually said about their hearing loss. So we have a question, what are the recommended ages for the Unihilo?
So the Unihilo was developed on kids who were, or the cohort that was used for development was age 9 to 17.
And the ages
in our study, our kids were aged 8 to 14.
And the ages were taken from some colleagues of ours who are very much into development of condition-specific patient-reported outcomes and they felt that 8 to 9 is kind of the age when people are reliably able to share their experiences and to report on their experiences. And of course, it's different. You know, some kids are more insightful than others, but just in general, that's thought to be the age of self-report, around 7 to 8. So while we're fielding questions, and we'll take, let's see, sorry, let me just, yeah, we'll take just a couple more questions. But the instrument was developed and then COVID hit. And so we got stalled on the validation ultimately, but I think we'll get back to it. So a question, I was able to find the SSQ online for free with ease. I'm not finding the Unihilo. If we want to use this tool, where can we find it?
Oh, thank you for asking that question. It is available with the Purcell publication in 2018. I'm not clear on which publication that was with, but it was also republished with a different formatting in the American Journal of Audiology in 2024. I believe it was published, I believe, in November, right before the ASHA, the most recent ASHA conference. So it would be available there. And if you want to reach out, we can also send it to you.
I can find it in the chat.
Oh yeah, Erin will find it and put it in the chat. What could you use to, oh, sorry, I'm going to read that next question. What could you use to indicate to a school district the importance of support for a child with unilateral hearing loss? That's a really great question. I would say using parent report, teacher report, as well as student report of difficulties. But I would say that there's, you know, a ton of literature out there to show the difficulties that kids can have, the risks that they have in academic settings. We will talk a little bit in the next presentation about speech and noise performance, and schools are notoriously noisy environments, so we'll talk a little bit about speech understanding and noise in the next presentation. But these are all really good literature pieces to share with school districts to show, hey, you know, kids are at risk. Even if this person is not struggling right now, this is a possibility. So let's get them some intervention sooner rather than later.
The next question, are the SSQ and Unihilo measures more appropriate for audiologists to complete with clients, or can SLPs also use these to track student perspectives?
Absolutely. SLPs can definitely use these as well. They were designed to inform hearing healthcare providers about gaps and accommodations, but I certainly don't see why it couldn't inform SLPs and school districts as well. It's pretty easily administered.
Next question, regarding the poor correlation for pediatric SSQ, did you look at the differences between ages that participated?
We did. So the pediatric SSQ, I believe, was developed in kids who are a little bit older. So I believe age 11 to 18 or 11 to 17, so a little bit older than our particular cohort. So that is definitely a possibility that could be explaining the poor correlation.
All right, it looks like we have time for one more question. The functional listening evaluation is a good tool for schools, and SLPs can perform the evaluation. It looks at the effect of noise and distance. So that gets to functioning listening evaluation.
Thank you, Lydia. So I did want to point out that Dr. Rogers spearheaded this study back when she was here at Seattle Children's, and I inherited it from her. So she is an excellent audiologist and
one of the original PIs.
One of the original PIs of the study. So thank you so much, Dr. Rogers, for your contribution and your study design.
And I like the, you know, I think the Unihilo has some potential. I like the Vanderbilt group's approach of pegging it to pictures.
Absolutely. I think that is definitely a way that we can use it for a younger cohort too. We did notice that that reading was a little bit harder for the younger kids in our study, especially because of COVID. Kindergarten was online, you know, that's prime time. We're learning reading and things like that. So there was a little bit of, that's another caveat to the study, is that the COVID pandemic really did impact us in more ways than one.
Yes. Thank you very much, Dr. Chang. That was
All right,
excellent.
thank you so much.